Let's do a basic overview of acid-base disorders, an approach to choosing which blood gas you're going to order, how to interpret those blood gases, and this is just for internal medicine interns. This is not going to be comprehensive. It's not going to be something that you could take to the medical ICU and think that you know everything there is to know by any means. It's going to focus on the most common scenarios and conditions, and some things are oversimplified just to make it approachable and more straightforward. So if you're going to get a blood gas, let's determine which type of blood gas we're going to get and which one tells you what information. If you're going to get an arterial blood gas, be aware that an RT is going to poke a needle in the patient's radial artery. It's going to be more painful, but it gives you a precise measurement of the oxygen in the arterial system. So if you're trying to determine the PaO2, the arterial oxygen tension of the blood, relevant for patients with ARDS, for example, then you need an ABG, because the oxygen content of a VBG is not very useful. But a VBG is a venous stick, can be done by any nurse, and it provides pH, PCO2. It'll list the O2, it'll list bicarb. Those things I think you shouldn't really be looking at with a VBG. But the VBG is fairly reliable for pH and PCO2. You just need to be aware that there's a small conversion. And so simplicity, VBG wins. Detailed, accurate oxygen information, ABG wins. When do you need an ABG? Not that often. But if you're in the medical ICU, they're going to be more common. Many of your patients in the medical ICU will have an arterial line where they can just pull an ABG sample straight from. And in that circumstance, all of my hoo-ha about it being uncomfortable and cumbersome is sort of out the window. But you need it often to determine ARDS severity and to estimate the PaO2 to FiO2 ratio. FiO2 is the fraction of oxygen being provided to the patient, usually on a ventilator in that circumstance. But another situation outside of ARDS where getting an ABG is helpful. Imagine you have somebody who you're looking at the monitor, and here's the O2 thingy duty, and it's kind of flat, and the O2 sats are in the 70s. But you look at the patient and they look fantastic, or it doesn't correlate because their lungs look normal on the x-ray. You might suspect that they have some sort of alternative hemoglobin, such as methemoglobinemia or carbon monoxide toxicity in the right circumstance. That might be an example where an ABG is useful, because an ABG includes parameters for carboxyhemoglobin and it can measure the fraction of methemoglobin. Additionally, in people who have severe vascular disease, their blood flow may be subpar to the fingertip. If you ever go in a room and someone has the little pulse ox monitor thing on their ear, that's a good sign that they have poor perfusion peripherally, or they're delirious and they're pulling the probe off. But in general, if you see a probe up here, it's often going to have trouble reading the O2 sat. Very common for the RNs to be calling you about O2 sats in the 70s, and you go look and it's on the patient's ear, and then you look at the monitor, and on that monitor where you're looking at the SpO2, the oxygen percentage, right? You look at that percentage, and it should be giving you a good waveform, okay? And if you look at it and it's giving you this thing, it's going all over the place and it's not correlating, or it's not a good waveform, then this pulse ox is not reading accurately. And this happens in the floor, happens in the ICU. In the ICU, in someone who's critically ill, that could mean something a lot different. For someone who's otherwise doing okay, who's on the floor, this just means that your O2 sat probe is in a bad position. Getting an ABG in that circumstance could prove to you that the patient's oxygen is normal in the blood. And if the nurses have put the patient on a boatload of oxygen in the interim while you're figuring this out, you could use the ABG to show that they don't need that much oxygen. When can we get a VBG? Pretty much most of the time. So it's pretty uncommon that I shoot for an ABG unless someone has an A line. I think that COPD patients, when you're looking at the pH and the CO2, there's never a circumstance where I'm running for an ABG. DKA, I can't think of when I've ever needed an ABG for DKA or for another metabolic acidosis situation. So I would just veer on the side of ordering VBGs for most of your floor patients, step down patients, people who you're looking for the pH on or the PCO2. I would stick with the VBG. And knowing that, you just got to realize there's a slight conversion. So the pH is a little bit lower because there's a little bit more, acid in the venous system, and the PCO2 is a little bit higher. And if you're trending just VBGs, then you have a reference for where they were earlier in the day or the day before. And then I'm not actively converting back and forth. I'm just looking to see, is it getting better? Is it getting worse? And if it's close to 7.3, then they're fairly close to 7.35. But, about 0.03 is the conversion that I usually go for the pH. And then again, looking at the telemetry monitor, where if someone, it's very common, you're going to be asked by staff, do you want an ABG? For someone who is on, let's say, 4 liters of oxygen, and someone whose O2 sats are 98% on the monitor. In that circumstance, I look at the monitor, I'm looking at that O2 sat that's excellent, they're on oxygen, they're stable on that degree of oxygen. An ABG would only tell me, the PaO2 on a VBG is going to correlate to what the oxygen saturation is on the monitor. So it isn't going to tell me if they're desatting and this is missing it. It's not going to give you any new information. And clinically speaking, what's way more important than this is making sure that whatever amount of oxygen is on your patient's airway is comfortable for them, their breathing is comfortable, and starting a workup to identify why their oxygen requirement is going up, and then coming up with a plan to make it better. And that's just the long story here. Is VBG is my preference and belief that it's probably better than an ABG. Certainly not a robust set of guidelines to really hammer into you that that's the right thing to do all the time. It's very much different attendings will ask for you to order different things, and staff will ask for different things. And in general, you're the intern, and if your attending wants an ABG, don't put up a fight and be like, well, I saw this online recorded lecture that ABGs are bad. ABGs aren't bad. They're just often unnecessary, but everyone's different. Respiratory acidosis. So when are you going to see this? Very common with COPD exacerbations, air trapping, expansion of the thorax, poor exchange of CO2 and CO2 retention. When you excessively sedate somebody, they can develop respiratory acidosis if they stop breathing. And then, in less common examples, if you have someone who's got big bilateral effusions, if this is the box of your thorax and here's your heart, if you've got effusions that are up to here bilaterally, and you're someone who's maybe in the hospital, a little bit delirious, who's not taking deep breaths and kind of also has some atelectasis down here, then look at the amount of airway space you have for exchange. It's not much. So in those circumstances, when the thorax is compressed by acute ongoing processes, it's certainly possible to develop CO2 retention and acidosis. All right, and clinically speaking, you might, the presentation of hypercarbia is variable. There's reportedly this agitation that people can get when they start to retain carbon dioxide. I've maybe seen this once or twice, but in general, you're going to be thinking about getting a VBG anytime you see somebody in the right setting who's just wiped out, who's lethargic, poorly responsive, who's a lot sleepier than they were earlier in the day. The classic picture is your maybe COPD patient who is already here with an exacerbation, who was wheezing earlier, is still wheezing a little bit now, but they were awake earlier and the notes said they were ANO times 3. You go in the room, now they're difficult to arouse, very sleepy, still breathing a little hard, but they're just not able to their mentation has declined. And that would be a time when I would jump and get a VBG. And in COPD, a lot of factors are contributing to, retention of CO2. A lot of it is back down to the, what's happening at the alveolus, right? So just the loss of diffusion or, exchange to airway to exchange CO2 plays a big role, but also increased respiratory rate in this population is contributing to air trapping and reducing their ability to blow off CO2. And additionally, if their O2 sats are titrated too high, like greater than 95%, or titrated to 100%, that can cause VQ mismatch, in addition to other mechanisms that increased oxygen leads to CO2 retention. And putting that all together, these are the general ways that this population can retain CO2. Additionally, if you know somebody just based on old VBGs and their past medical record that they're prone to developing hypercarbic respiratory failure, you want to be very careful with sedatives like benzos and opiates, and I would use lower doses in this population. If you've listened to anything else I put on here, I wouldn't use benzos at all, but that's a fairly political conversation. The CO2 is high. So if my intern came to me and said, Robert, the CO2 is 120, I don't have a reaction to the CO2. I care about the pH. If your CO2 is infinity, that's great. What's your pH? If your pH is 6.8, that's not good. If your pH is 7.36, like this, and your CO2 is 85, okay, that's fine. So that's just to point out here that the pH is what dictates clinically how you should be reacting. If somebody has compensated respiratory acidosis, as in this case, the BMP and the labs would show you a bicarb of 36, normal is usually 24. So this person is rolling high, probably like this all the time. And maybe they're on nightly BiPAP to help keep this PCO2 kind of where it is to keep them compensated. But some patients don't even need that. Some patients compensate over time, their kidneys work, and they live like this. And certainly if they're having an acute exacerbation, you might get a VBG if their breathing looks worse. And if that pH has dropped down to less than 7.3, now I'm interested. Somebody's short of breath, they're getting acidotic, that CO2 might be greater than 100 now. That's a very different circumstance. And in that circumstance, the CO2 still isn't guiding me, it's the pH. So pH matters, and if you ever present a gas to your attending or senior, just know that, and you'll be clinically astute if you're thinking about the pH rather than the quantity of the CO2. All right, and that's more what I'm saying here. Chronic compensation, CO2 doesn't matter. And let's go through a couple of scenarios for respiratory acidosis. And your call for the COPD patient already here with an exacerbation, and their shortness of breath has been getting worse, but the nurse calls you overnight, and you go over there, and the patient is not just short of breath, he's got increased work of breathing, he's using accessory muscles, he looks very bad. You get a blood gas, the pH is 7.15, PCO2 is greater than 100, and the guy's breathing almost 40 times a minute. Now, for me, anytime someone's breathing greater than 30 times a minute, that's concerning. I consider that a vital sign abnormality that's getting into the range of unstable. So this needs immediate intervention. And in addition to that, that pH is going to need immediate intervention as well. So what are we going to do here? So first of all, the overall respiratory stability is automatically unstable in the context that this patient is extremely tachypnic and using accessory muscles. So this patient needs immediate support. They need, if he's awake enough, a BiPAP for multiple reasons here. But you're also going to do some nebs. In a case like this, I would blast this person with 3 duo nebs back to back to back. That's what you would do in the ER if this person rolled in under the same circumstance. And in a case like this, there's much more gray in the middle between someone who's doing fantastic and someone who's crashing like this. But in this circumstance, with the increased work of breathing, if there's not an immediate improvement with nebs and putting a mask on this patient, and even if there is some improvement, you should call the ICU. This is someone who, without the ability to put on a BiPAP mask, arguably is at a point when they should be intubated and may need to be intubated even if they're treated the right way. And that's generally what I put here. Level of care has to be increased, but that won't be enough. If you're the intern, you really shouldn't be alone at our hospital in this circumstance, but if you were, you need to stay at bedside, stabilize the respiratory status, work with the RT to find a BiPAP or another therapy to make this patient comfortable, but a BiPAP in this circumstance is really the name of the game. And the nebs can go through the BiPAP. And like we said, 3 in a row would be a good idea. Just in case you can't read my handwriting back there, it's written down here. Scenario 2, you're called for this VBG by the nurse, pH is 7.29, and the CO2 is 84. Patient's bicarb is 31, so he's somewhat compensating. And you look at old VBGs, and the guy's always rolling in the 70s. But as you see here, he is a little bit acidotic. So even if you convert from VBG to ABG, that's still a little bit low, maybe 7.32. And that CO2 is also a little bit higher than his baseline. So this might make me think, okay, we're heading the wrong direction. We should probably intervene to some extent to make sure that this is getting better and track the blood gas to make sure that it doesn't get too much worse. He's already admitted with a COPD exacerbation, so earlier in the day they already knew he was wheezing, and here, because he was more short of breath than at baseline, you go to assess this patient. It's middle of the night and the patient is sleepy but looks comfortable to you. He's on like 2 liters of oxygen. Clinically does not look anything like the person in scenario 1. Still wheezing a little bit though. So what should we do now? I think there's several different ways you could intervene in this scenario. So first option is I want to wake the patient up, make sure that this patient can follow commands, and make sure that this patient is not showing any signs of respiratory distress even once I wake them up. And let's say I do that and he passes all those tests, but he's a little bit sleepy, a little bit lethargic. And we've got a gas saying that he's heading the wrong direction. So, first option is to put this patient in the step-down unit and try BiPAP, and see if that leads to an improvement. And in the first scenario, I put the BiPAP on and I'm at bedside, and I'm looking to make sure that that makes the patient's respiratory distress get better immediately. In this case, he's not in distress. So in this case, I'm going to want to repeat VBG maybe in 1 to 2 hours to make sure that things are going the right direction. And if things are going the right direction, and if I come back in 1 to 2 hours and this patient is still following commands, waking up appropriately, and looks stable, then you found your answer. And then in addition to the BiPAP, I would still do some duo nebs for this patient just to help reduce that wheezing and help to make sure things are as open as they possibly can be. That's all pretty much written down here in case you can't read my handwriting. All right. And one other option, and I've done this a little bit, is if I give someone a couple of duo nebs, if they were short of breath, if their VBG was slightly abnormal, and maybe you didn't completely buy the VBG, so you want to get a repeat in a pretty short interval. So 30 minutes later, you come back and get another VBG and see if the nebs help to open things up and see if they're looking better. In this case, I might veer on the side of trying the BiPAP if they're safe for it. But there are some cases where you have someone who's older, someone who has a history of aspiration, and someone who's just a little bit less of an optimal candidate to try on a BiPAP based on contraindications. So in that circumstance, I might also think that this person is not really someone who needs an ICU consult at this point in time. So in that circumstance, I might be inclined to try some breathing treatments, make sure they're getting steroids, and look at the x-ray and see if there's any other acute process going on like fluid or pneumonia that isn't being completely treated, and maybe target those things. But get a gas after a short amount of time and try to prove the numbers are going in the right direction to avoid having to escalate care or to try a BiPAP on someone who's not a great candidate for it. All right, so scenario 3, you're called for this person who's somnolent, barely responsive. You notice they're breathing less than 10 times a minute, their pupils are pinpoint, and you get a gas showing that their pH is 7.1, their PCO2 is 84. What now? Okay, well, what does this sound like? Again, you're the night person, you roll in there and you encounter this. To me, again, this is an illness script, okay? So to me, this describes someone who is excessively sedated, and unless they have a history of COPD and they've been here for this and that, but even in that case, the fact that they're breathing less than 10 times a minute and have pinpoint pupils makes me concerned that there's a contribution of opiate overdose here. And so I would Narcan. And if the patient wakes up, fantastic. That's your answer. If the patient wakes up a little bit, give them more Narcan. If the patient's starting to wake up even more, maybe put them on a Narcan drip. If the patient is still not waking up or didn't have the response you hoped for with Narcan, then you should probably call the ICU. One key point to those previous scenarios we did is that those patients were all breathing fairly quickly, greater than 20 times a minute for the most part, sometimes greater than 30. So for a person with a COPD exacerbation to be breathing this slow would be questionable. It really would argue against that as the illness script, okay? So that's important to be aware of. And in general, if you're dealing with somebody who may have overdosed on opiates or another sedative, that's not somebody who is really fit to trial BiPAP. That's really not what BiPAP is made for. It's somewhat of a contraindication. This person is even if they're a young, healthy person, is still going to be pretty high risk for aspirating if you're putting positive pressure down their throat. So it's just something to be aware of. But keep your differential diagnosis at play as well, which is really what this scenario is about. But big picture, there's many other scenarios I could have included here. If you're on days or nights, there are many situations that are very gray and mucky, and it's just not clear, if you have to do anything right that second, or if you can trend and wait and see the gases and see where you should take things. But I gave you some severe examples and some less severe examples. Hopefully this gives you some context for what resources you have, and that would be the goal, okay? And use VVGs because they're generally better. Metabolic acidosis, this will be a lot more brief, but look for the anion gap. It's in the BMP, and if you're really scientific, you can calculate it on your own. But why would people have an anion gap? Mud piles. We don't really think about mud piles as much when you're doing this all the time. You think about elevated lactic acid. That's a common cause of an anion gap acidosis. DKA, another common one. And then if you have a more stable patient, somebody who has ESRD, it is definitely possible to see an elevated anion gap due to retention of organic ions in the context of your kidneys not working. And those patients may have a normal pH if they're being dialyzed. If they're not being dialyzed, then again, you have your AEIOU, and patients with ESRD who aren't dialyzed become acidotic. And this is partly why they lose bicarb and they retain organic anions that have acidity and raise the anion gap. Somebody with a non-gap acidosis, there's a pretty narrow differential as far as I'm concerned, as far as what causes non-anion gap acidosis. So first, abnormal saline. If you have a DKA patient and give them 6 liters of normal saline, their CO2 on your BMP may go down, even if their pH gets better because you close their anion gap, because normal saline causes non-gap acidosis. And diarrhea. Diarrhea is the most common non-iatrogenic cause of anion or non-anion gap acidosis. So I would never want to. So if you were my intern and you admitted somebody with a CO2 or a bicarb on their BMP of 6, and you didn't ask them if they were having diarrhea, assuming their anion gap is closed, then that would be the teaching pearl there. So if somebody's having 20 stools a day, their bicarb will be that low, and it's all from diarrhea. The opposite happens with vomiting. For metabolic acidosis, very brief here, if you're in the medical ICU, someone's pH is dropping down to 7 or lower, kind of getting into that severe range. They may play around with bicarb drips and things of that nature, but really the only time we have to think about treating an acidosis, other than treating the underlying cause of why they have an acidosis, is CKD patients. You want to make sure they're getting their sodium bicarb tablets. If they're already on that at home, consider starting that for CKD patients if their bicarb is low on their BMP. But in general, CKD is the one indication where I'm treating this outside of the ICU. And in the ICU, it's still a very mixed, controversial thing that I wouldn't expect most senior residents to be, making those calls on their own. And if they are, you can't make a decision about using bicarb in someone who's on a ventilator without thinking about how you're going to handle the ventilator, because you're dealing with an equilibrium and you may worsen their overall acidosis even if you're giving bicarb as it equilibrates into CO2. Another scenario for you here, you got somebody with sepsis, a lactate of almost 5, but their pH on the VBG looks pretty good. In fact, that pH on the VBG doesn't get me excited. And just for context, if the pH is greater than 7.3, I'm not interested. I think they're doing good, unless things are getting worse clinically. pH in the 7.21 to 7.3 area is probably something that if you have a plan that's going to make this better quickly, they're probably okay to be in the step-down unit depending on the underlying cause. pH less than 7.2 is somebody who's usually in the ICU. pHs that are getting closer to 7.0 or into the 6s is make it better now because cardiac arrest is around the corner. So back to this scenario, we've got our pH there. Our PCO2 is actually in the lower range. It's below 35. So that's either compensation or inadequate compensation, depending on other factors like the Winter's formula. But this patient's on antibiotics, they're treating sepsis, he's feeling better, and you get called by the nurse because the patient's breathing 32 times a minute. You go look at the patient, and he looks great. He's got 2 thumbs up. He's telling you, I feel good, doc. And you're asking him about shortness of breath, and he says, nope, I'm not short of breath at all. And if your lactate is that high, that's probably because, guess what, you're compensating. And in this context, that PCO2 probably should have been lower. It looks like he's compensating quite well. Now, you could trim the VBG here if you're concerned. If this isn't getting better after a little while, you might trim the VBG just to make sure that the pH is not dropping and to make sure that this patient is not starting to retain CO2, which might be a sign that he's tiring out. And this is someone starting with a lactate over 4 with sepsis who maybe should be in the ICU to begin with. Very quickly here, septic shock, other causes of lactic acidosis, you're going to be in the ICU for that. So I really don't have anything to say about that. But if you ever have someone whose lactic acid is like 3 to 4 and you're trending it and it's not going up, it's not going down, it's just flat, in those circumstances, just stop trending it. And if the pH is normal, and there's not something acute going on, and somebody has a metabolism error or they have liver or kidney disease, for whatever reason they're not clearing lactate, you just don't want to spend all your brain power trending it just to trend it, because you're really not doing anything for anybody or yourself. Very quickly, DKA, think about it in somebody who is a type 1 diabetic with hyperglycemia. That's straightforward, right? They may be altered, they may be breathing, huffing and puffing like they're going to blow your house down. And diagnostic features for DKA, you usually would see acidosis, right? I've seen as low as 6.8 pH in this case. What I'm looking for to confirm a diagnosis is elevated glucose, but also elevated anion gap. If you don't have an anion gap, you don't have DKA. And ketones in the urine, ketones in the blood, if you measure a beta-hydroxybutyrate, that would help to confirm your diagnosis. Always search for an underlying cause, and you'll start residency, and this seems silly to put in here right now. You guys probably know this better than anybody. As the residency goes on, people sometimes look for the simplest answer to each problem. And with DKA, it's very easy to convince yourself that so-and-so forgot their insulin yesterday, that's why they're in DKA. Maybe that's the case, but that should be the last result that you come to rationalize why someone's in DKA. Find a better reason. And then the management of DKA, once you confirm that's what you're taking care of, this often happens in the ER. They have the burden of really identifying most of the time, this is DKA, they have an anion gap, we have to start the DKA protocol. And so for you, if you're admitting these patients, you're often continuing the DKA protocol in the ICU or in the step-down unit. And continuing the protocol really is based on an order set that is really, honestly, I don't know how much I love order sets for most things, but for DKA, order sets are the best thing ever. If someone says they don't like order sets, I would say, well, hold on. You're not thinking about DKA, because this works so well. Once they're on this order set, as long as nothing acute happens before you start it or right after you start it, once they're on the order set and the insulin infusion is going, their fluids are going in, you're in autopilot mode. So it's good stuff. The labs are Q3 when they're in DKA. Once that gap is closed and if their electrolytes are looking normal, you might consider spacing out those labs a little bit so the nurses are a little bit less annoyed with you. And their glucose is measured every 1 hour when they're in DKA. So this is notoriously the treatment and the diagnosis that nurses probably hate more than anybody, because they've got to constantly be in there checking the glucose. And I don't blame them. It's very frustrating. And what happens is you're often approached by the bedside nurse, and again, it's not their fault. They're asking you, though, can you stop the insulin drip? Can we give them a diet? Because their anion gap is closed, their glucose is 150, and it's 6 in the morning? And the answer is, well, it's complicated. Maybe we could consider starting sub-Q insulin, but that depends on this patient has to be ready to eat a meal and hold it down. So usually this is a day team decision, and it's a decision that you should make as a senior. I may make this decision on my own, but it's never wrong to make sure you're attending and you're on the same page about making this call. But you want to do it once the patient can eat and hold the meal down, and the gap must be closed. And the bicarb should be, closer to normal as well. You don't want to do this if the bicarb is still below 10, for example. But you give the first dose of their sub-Q insulin, like Lantus, give them a meal at the same time, and you let the drip go on for approximately 2 hours. Then you can stop the drip. So unfortunately, to every nurse who ever asked me to stop the drip early, the answer was, can't do it, and it's going to be a while. So it's not your fault. That's how we treat this condition. Blame the people who write the guidelines, I guess, right?